converting manual SICS to FACO step by step. May I call upon the other faculties of this course, Dr. Lalu Komi, Dr. Ayam Mohanto, to come and take the stage, Dr. Manush Ghosh. As you all must be knowing that, this is a very important area, and may I disclose that the authors have no financial interest in any products mentioned in this presentation. Well, India has been gradually transforming from the safe, secure SICS to a more acceptable and a more reward-giving FACO emulsification surgery. The reasons have been our economy is getting every day better, and we can't afford this surgery. Cataracts, we have worked hard, cataracts to SICS, and the cataracts are becoming softer. The machines are getting better and help us to deal with even the hardest of the cataracts, and the technology is becoming more Indian by the day. As I was talking to you, it is this wow factor that we get after FACO emulsification, which really scores over SICS, and the feeling that I have not been operated on the very first day, post-operative day of FACO emulsification. Well, we are all from Disha Eye Hospitals, and if you follow our statistics, this has been the total number of cataracts close to 40,000 now. And if you take the FACO curve, that's how it's following the growth of cataract surgery in our institution. Whereas if you take SICS, it is on the decline. So all said and done, we have to admit that we have to switch over from SICS to FACO emulsification. This course is all about how we're going to do that. Now, the first thing first, we do this surgery very well, and so we go ahead with SICS. First, let us understand that we must procure a good microscope and reasonably good FACO machines. The Indian machines with no financial interest from Swami are equally good. And then we should be trying FACO emulsification for almost every case. And how do we go about doing this? Is doing the SICS incision, but as you noticed, keeping the incision as close to the cornea so that we can use it for FACO emulsification. The normal SICS incision is kept very close to the limbus. And we should be choosing the ideal cases to start with, which means that you see that we make a small entry, a 3.8 millimeter entry. We stain the capsule with trypan blue so that it helps us to do a good rhexis, because FACO emulsification is an endocapsular technique and we need a good rhexis. To begin with, I would emphasize that we also need a big rhexis, because it should not come in the way of our FACO emulsification and subsequent procedures, and we can convert to manual SICS if we are in trouble. So we need to have the stain in the rhexis, to see the rhexis all through the FACO emulsification procedure to begin with, and that is why I stain all the rhexis in the conversional state. What is important in the conversional state is to choose the ideal cases first, which would mean that you should not choose eyes which do not dilate properly, when the cornea is hazy, the exposure is not good, it is a deep set eye. At the same time, very soft cataracts and very hard cataracts are not good for phacoemulsification. So choose a cataract like this, grade 2, grade 3 cataract, which can be trenched, separated, chopped as per requirement. Keep using the left hand as much. In this video, see the surgeons using the left hand as much, because this becomes an integral training of the left hand to move with the right hand as is required in phacoemulsification. We must not also choose eyes with poor red glows. Neither should we choose very shallow AC or hypermetropic cases, or nor we should choose deep chamber cases like the myopic ones. At any point of time, if you are not comfortable, we can always convert and proceed as in SICS. So the emphasis is on the point that try phacoemulsification in every case to begin with. Of course, do choose your cases where you will complete more of them. And whenever you are in trouble, our good friend SICS, which we will be doing for so many years, is always there and we can easily convert. And the next video that we will be taking up with you is a both side simulation, because the wet labs parallelly are equally as important in training ourselves into phacoemulsification, because all that we need to learn as an SICS surgeon switching over to phacoemulsification is which cases to do, how to do it, and it's only about nuclear management, because we are always conversant with the rexes, the hydrodissection, and this is also important. To get accustomed with the phaco machine, this is the safest step which can be done first, the IA, the irrigation aspiration. And here there is a lot of epinucleus left as the surgeon will delaminate before the surgery. So, one good trick of getting these things out is to go catch a thing and then rub with the other left-hand instrument or irrigating instrument for cleaning up. So please understand that in all cases do automated IA, that is the first introduction to the machine, because all we can probably do is create a PC lens, then we can do vitrectomy and place in an intraocular lens. So this is the first step. The second step is, which goes on simultaneously and maybe before the first one, is to have your wet lab training seriously. You can set this up, there's nothing hi-fi about it. You can use the same microscope, the same phaco machine. You need to take a roadside which you can easily procure from the meat shop, and you need to fix this eye properly so that it doesn't move during the procedure. If you don't have a Marty's eye like this, we will show you how you can just fix it on a thermocol board. The idea is that it shouldn't move during the training procedure. So you can have a thermocol block where we have created a small oval depression to house the both side, and then fix the muscles with the both clips. The other thing that we noticed was to blow a little viscoelastic into the eye so that the eye is very tight and you can actually carry on with this both side wet lab. The both side works extremely well because you can do an incision. Now you may be asking me why we are doing an SICS incision here if we want to learn phaco. This will become evident as the video goes on. As I wanted to tell you that you can do split the sclera and the cornea equally effectively in the both side. And here is the phaco incision. Viscoelastic is given to enlarge the incision. For the wet lab, we would say that recommend that you do a small excess because we need to house something here. Now the small, this is the best way to master the rexus also. See here the surgeon is trying an onion whorl rexus, which is a slightly difficult art which needs to be done in hypomature cataracts, Morganian cataracts, and then sculpt a hole with the phaco machine in the Bose clear nucleus. So, and please note that the left-hand instrument is slightly inside into the cornea because the both side cornea is very deep. So we need to have the chopper here and the phaco incision around here. Now we are enlarging the SICS incision. These pigments do come in from time to time, but you can always chop them away. Now the SICS nucleus that you have done the morning, or you can take your previous day's cases, they can be made hard by putting it in formalin for a day. And you can dial the same way, so you have to do the reverse when you do in SICS, dial the nucleus into that rexus, and now you have a perfect simulation in the eye where you can actually go ahead and do phaco emulsification. You want to learn the job, you can learn this direct job. You want to learn some procedure, you want to perfect the procedure. What we want to convey is this is a perfect simulation, and if you do 20, 100 nucleus, you are not spoiling any human eye until you are sure that you can do it, and then only you can go ahead with your switching over to phaco from SICS in human eye. So yes, it is simple. If you can do it in the goat side, you can definitely do it in the human eye. This third area that I would like to take up with you is phacodynamics. We need to understand a little bit of this. Without complicating things, it is just an irrigation aspiration system where we have emulsification for our ultrasound for harder things which we cannot aspirate. So this depends upon a gravity-filled passive fluid system, which is the infusion, and this is the phaco machine that houses the motor, and this is the cassette, and this leads to a blue wire which takes the electrical signals to the ultrasound, and two tubings for the aspiration and the irrigation up to the handpiece. So this basically is the instrument that we need to work with. Now most of these machines are safe machines, are peristaltic machines, and there is nothing great about it. It's like the way we used to fill up our old ink pens. So there are the tubings are pinched by the roller balls every now and then, and that is what causes the aspiration. So there is a motor which rotates these tubings around those roller balls. Faster the machine rotates, more is the aspiration flow. Slower the machine rotates, slower is the aspiration flow. As simple as that. So as I was telling you, it is phaco aspiration. What we can't aspirate, we emulsify and aspirate. So it is nothing out of the world, or those big machines shouldn't be scaring us. In foot position 1, irrigation is activated. In foot position 2, irrigation and aspiration flow is activated. And in foot position 3, all three, that is the phaco is activated, more important. Irrigation is a passive process in foot position 1, 2 and 3. When irrigation depends upon the water height, the opening size of the bore of the tube, the number of openings in the sleeve, the size of the sleeve size, the openings in the sleeve. But this is almost constant for a particular machine or a particular setup. And irrigation is compensated by aspiration plus a little bit of fluid which leaks from the sides. Now irrigation is more, the chamber deepens, and if the aspiration and leakage is more, the chamber will shallow. So if there is no aspiration or leakage as in foot position 1, irrigation is stopped by the intraocular pressure, which then becomes equal to the air pressure in the bottle. In foot position 2, there is aspiration flow, and greater the aspiration flow, more things will come to the tip of the nucleus. So when the tip is occluded by a nuclear fragment which is come, and the vacuum develops in foot position 2. Now, the preset vacuum which we have set, say 200, say 300, that determines that the motor will continue to rotate at the speed set by the aspiration flow, which is say 30 cc per minute, until the preset vacuum is achieved. So quicker the aspiration flow, quicker the vacuum develops. And as the tip is occluded, no fluid comes out at this stage and the tubings collapse. The vacuum is measured by measuring the collapse of this tube by a vacuum sensor. And when the collapse reaches the preset vacuum, that is say 200 or 300, the motor stops. Thereby, the aspiration flow stops. The vacuum again builds up, and the vacuum gives the holding power to chop and emulsify. So energy is delivered in foot position 3. As the energy is delivered, the occlusion is broken and the vacuum comes down. The tubings gradually swell, and the sensor activates the motor and the aspiration flow starts all over again. So the ease of collapse and swelling of the tube is called the compliance. The newer machines have better compliance or use less compliant tubing, so surge is minimized. They use stronger motors also. The compliance of the tubing is the most important thing that protects surge. When the flow is resumed, the whole cycle and the nucleus is occluded in the tip and the vacuum develops again. So this is the cycle which keeps on repeating again and again. So while we are trenching, we need power, but we don't need much flow. So we keep it between 15 to 20 cc. And the aspiration and the vacuum, we also need not hold. So we can keep it at 40 to 60 to aspirate whatever nucleus material we are quenching. But when we want to impel, when we get it, it's like hitting a nail in the wall, so we need a burst or panel or even continuous energy. And the flow should be 30 to 40 because we want to hold immediately after impelling, so it must be 300 to 400. The similar parameters would work good for during the emulsification process also. Now this is to show that if we increase the irrigation, we are actually lifting the bottom height. See the irrigation increase and the chamber deepens. So this is to say that irrigation is passive, it is just dependent on the bottle height. Now to give you an example of the aspiration flow, you can follow the parameters here. As we raise the aspiration flow, you know this fragment which is not aspiration, of course, 60 is not desirable. Now, if we have the downside of having higher aspiration flows are this: the fragments cause a lot of turbulence in the air, which is not good for the body. And now see the vacuum. See the vacuum rise here. So there the energy is being used, the vacuum is held and the shock is executed. So the vacuum gives us the hold of the nucleus to chop. So also you see that the nucleus, the vacuum is high. So this is how you hold and then chop. Then during the emulsification process, please focus your attention to this part. See that this is the energy and this is the vacuum. See, they will always keep on jumping. The energy, the vacuum breaks again, develops, the breaks again, develops, the flow stops, again it resumes. So this is a cycle, as I told you, which goes on continuously. Now if we are using too much of power without effective vacuum and effective aspiration, we will actually shatter the nucleus. It keeps on flying away from the tip. So that is called shatter. Now surge, for obvious reasons, it's been done in a category type. If you use too much vacuum, too much energy, what will happen? Things will happen very suddenly. The occlusion break will be sudden and the machine cannot take over, and that's how you have a incident here. So giving you a feel of what things can go wrong and what is the right way of doing things. Sometimes around this you see the vacuum is around 330, but nothing is happening, there is no hold. Actually the tubings or the tip has got occluded, so you need to prime the machine and change the tip. So these are machine problems which we have to solve on a day-to-day basis. Manush, our FACO trainer, enjoys an apple after every training session. So it's very simple. You impel, you emulsify, and enjoy FACO emulsification. Well, these were the first basics, and now to get into the subject proper, I request Dr. Manush Ghosh to come and take up drenching and practically emulsify.
Good morning to all of you. So by this time you have learned the thermodynamics and capsule axis, hydrolysis and nuclear rotation. So next comes the management of the nucleus. So that I will cover in the next few slides. For the drenching, angulation of the tip is important. Different angulation of the tips are available. One is 45 degree, it starts more than drench. 15 degree, because it's almost round configuration, so it gives more occlusion than drenching. 0 degree, it's totally round, it gives only occlusion, no drenching. So this will be ideal for the chopping purpose. And 30 degree is balance between 45 and 15, so it is ideal for drenching. Coming to the machine setting, aspiration flow should be 15 to 20 cc in the lower end, because during drenching we have no flowability is required and neither the occlusion. And vacuum should be also in the lower range, because we do not want any occlusion at this stage. On the contrary, occlusion occurs, we push the nucleus. So vacuum setting should be very minimal, and because there will be occlusion and we will push the nucleus. Power setting will depend on the hardness of the nucleus. Harder the nucleus, higher will be the power setting. So it will range between the 40 to 80%. In softer cataract, softer energy like micropulse or torsional can be used. deep exposure of 1.5 millimeter should be done, otherwise you cannot do trenching. Coming to this animation of trenching, the trench should not cross the rexis margin, especially the initial field strokes, otherwise you will injure the rexis. So initial field strokes, you confine your trench within the rexis margin. Once you go deep, you can go beyond rexis margin, but initial field stroke, you must keep your trench within the rexis margin. If the cataract is hard, trench should be long and wide. And also, as I already mentioned, energy setting should be at the higher level. In softer cataract, trench should be soft and narrow, and obviously the energy setting should be at the lower level. The angle of attack, that means the angle between the tip of the phaco tip and the nucleus should be 45 degrees. So that will give you perfect trenching, or you may, or if its angle of attack is less, you may superficially chip the nucleus and injure the rexis margin. 1/3 of the tip should be buried in the nucleus to get the perfect trenching. If we bury the nucleus more than 1/3 of the tip, there will be occlusion and you can push the nucleus. And if you also less bury the tip, so you will not get adequate trenching. We know that human nucleus is bicomplex, so it is thickest and hardest at the center. So more tissue should be, as human nucleus is bicomplex and the central part is thickest and hardest, so more tissue should be trenched in the center, and also so no energy should be wasted while coming back, because if you continuously press the pedal, your energy will be wasted. More energy should be used to trench the center and refocus the microscope as you go further deep. Remove small chips carefully during deep trenching, especially when you are near the posterior capsule, or you can do a hole in the periphery. If you rotate the nucleus from the center of the trench, you get a small fulcrum, so you will not be able to rotate. But if you rotate from the periphery, you will get a bigger fulcrum and rotation will be easier. Rotate the nucleus 180 degree to start the upper part of the trench. So once you complete one half, rotate 180 degree and complete the other half. You can, by trenching, you can counterbalance by fixing the nucleus with CST hook or dummy. This video shows the superficial trench. This superficial trenching occurs because their power setting is less and the angle of attack is less. So we are ending up with a chip of the nucleus here. This is an example of a deeper trench. This occurs because instead of burying 1/3, we are burying almost full tip. So that's why we are getting the occlusion here. And this is dangerous. If you proceed like this, you push the nucleus instead of doing trenching. So during trenching, you must see whether your tip is getting occluded. In this, we are using a low power, or you are not pressing the foot pedal, so that's why you are not getting the adequate trench. So ideally the range width should be 1.5 effective width. So if your width is not 1.5, you will not go in the deeper because your sleeve will prevent you go into the deep. So ideally the range width should be 1.5 so that you can go further deep and make a deep range. So the tracking will be easier at the next stage. Coming to the tracking, use equal forces on either instrument in the depth of the tunnel. This is important, in the depth of the tunnel. If you use more force in the wide instrument, there is traction to the opposite zones. If you try to divide the superficial part, you will not get a crack. The crack should be initiated from the periphery to the center, and if the crack is incomplete, rotate the nucleus 180 degree and complete the crack from the other periphery. The center is hardest, so it is difficult to crack in the center, and also you do not get a good fulcrum by cracking in the center. See, we have made a trench, but trench is not sufficiently deep. So we place two instruments mistakenly and trying to crack because your trench is not deep enough. In spite of giving so much of force, you will not get cracked. In this case, we made a adequately deep good width trench, but mistakenly we are placing the instrument at the superficial part of the trench, and in spite of giving so much of force, we are not getting the crack. But once we correct and placing two instruments at the deepest part of the trench, that gives a good crack with little force. Now, once we complete the trench part, now we see how we can do the root water technique. This technique should be done especially at the beginning stage. We are making the limbal tunnel. Firstly, one plane, then 2.8 atom go into the utility into the stroma, then with pull down technique enter the antechamber. Use viscoelastic to deepen the chamber. Two side ports at 2.5 clock hour out of the main incision. Then making rexes either with cystitome or with phosphates, whatever you are comfortable. Capsule diameter should be 5 to 5.5 and complete the rexes. Then particle cleavage hybridization, you can see the nice cleavage with every hybridization, tap the central part and decompress. Now practice rotation bimanually. That gives you practice in making left hand dominant. Now the trenching part. So we are using the traditional ultrasound 60%, minimal vacuum 50 and aspiration flow rate 20. We have completed the trench one half, then we are completing the other half. So total from 6 o'clock, 9 o'clock or maybe 12 to 6 or 3 or 9 complete. Once one part is completed, rotate the nucleus 180 degree and trench 90 degree from the first trench. Go adequately deep. So once you make a perfect cross, place two instruments at the deepest part of the trench and track it. One half of the crack, then other half is cracked. Now rotate 90 degree and cracking is completed. Now for freely completely free fragments are there Now we are using the hyperpass mode for eating the fragments. So here we are using a little bit higher vacuum. So this higher vacuum gives the fragment to the tip. Use your left hand to realign the fragment. So using use of left hand is very important here. You have to continuously realign the fragment with phaco tip. And same procedure is repeated to other fragments. Thank you.
Is a very important aspect of the whole thing, because everything has to be watertight and slightly leaky to heat prevents the heat generation and the effects of it. To tell you all about this, Dr. Royan.
Good afternoon, all of you. I'll be talking on incision. As you all must be knowing that incision is the gateway to a very successful phacoemulsification. If you have a very leaky wound, the chamber will fluctuate continuously and interfering with your surgery. And if your incision is too tight, might produce wound burn and fish mouthing. Later on, you have to put a suture and all. So, Dr. Ghosh had already shown you how to put a clear corneal incision, and I will be showing you this particular incision through the by the help of an external camera. So, if we start it once again. See, first the vertical dip, then I proceed interstromal, then again a dip and entry into anterior chamber, and again parallel to the iris plate. So this is all about a 4-plane incision, which you might not do it initially, but ultimately your target should be doing a 4-plane incision so as to produce a watertight wound. And the side port incision should look towards the opposite side angle. And the side port should be 2 clock hours from the main incision. For a right-handed surgery, it should be on the left side 2 clock hours. It increases the maneuverability, minimizes the leak, minimizes stride. While maneuvering with instruments, there might be corneal stride. So if the side port is more than 2 clock hours, the chopper motion becomes more of a sweep. And if it is less than 2 clock hours, the hands become more crowded and the whole process of maneuvering will become very difficult. So after the conclusion of surgery, one should carefully hydrate the stroma, and also keep in mind that while doing so, keep very cautious about the basement detachment that might occur due to inadvertent seepage of water into the basement place. And every time you should assess the firmness and wound tightness. Sometimes the patient complains under topical anesthesia, the patient might complain that I can't see the light. So that means your wound is too tight, and so you just release some amount of BSS. A snugly fit phacoprobine incision gives a stable anterior chamber. A tight incision pinches the slit and reduces the flow, resulting in a shallow and unstable chamber. The ultrasound tip touches the incision and the heat is transferred to the incision wall, resulting in wound burn. Now this is a wound burn video. As you can see that if you notice this area, it's slowly turning chalky white. So this is a typical wound burn. which will ultimately lead to wound leak, and you have to put a suture at the end of the surgery. See, already while doing the trenches, see the energy is, the CD over here is almost 41. So that's too high an energy, and after the emulsification is complete, it will be even more. So you can see the clear-cut white chalky area over here indicating wound burn. So you need to put a suture in this particular case. So why wound burn occurs? The commonest cause is a tight wound. So always follow the manufacturer's recommendation of the phacoprobe. If the phacoprobe manufacturer says that you should put a 2.8, put a 2.8 and not a 2.7. And you should ensure fluid flow around the tip. Remove the viscoelastic adequately before applying energy, because these viscoelastics are good conductors of heat. So if you straight away go to the foot position 3 within the eye without slightly dissolving the visco around, it might lead to heat generation, and this heat is directly going to affect the endothelium. And maximum burn occurs during the tip occlusion and fragment removal, which is a no flow state. So when the tip is occluded, there is no flow and the energy is being applied, leading to wound burn. So I have already said that put a suture to minimize the wound margin or create a separate entry in case of wound leak. Now coming to stop and chop, this is the next technique which one should undergo after completing the 4-quadrant technique. And because this technique it mixes the good points of both the worlds, the 4-quadrant technique and the direct chop. So let's go about it. It was developed by Paul Koch. It's basically a combination of Kimball's nuclear preparation and Nakahara's in situ chop. So the step 1 is the creation of space within the cataract, it's done by trenching. The step 2 is the cracking part, and the step 3 is the chopping. So after successful trench is being made, the nuclear fragment has to be aligned correctly in order to achieve a total occlusion. So you see here, the bevel of the tip is not parallel to the wall of the trench. So this might not produce a good impaling. See, there is a gap, so it's not, the hold is not good. So now you correctly orient the nucleus along the bevel of the phaco tip, and again try doing it. You see, the hold is good. So this you have to keep in mind, that always orient the bevel of the tip parallel to the wall of the trench. Now a successful chop is achieved. If the probe is superficial, the hold is weak, and this can slip and injure the rexis. So we are in the stop and chop technique. We are first creating the trench, rotate the nucleus in order to complete the trench. This is how the trench is being done, and you can see the good permanent flow through the floor of the trench. Now with the help of two instruments, it can be either a phacoprobe or a blunt chopper, or it can be two other instruments. If you take out the phacoprobe, two different Finsky or Kugler hooks do. Now after impaling the nucleus, it is being divided. Orienting the nucleus along the bevel of the tip, impaling it and doing the chop. So after 4 or 5 fragments are being made, you can start emulsifying here each fragment. So in order to chop nicely, you have to grasp the collar and
horizontal chopping, we divide the nucleus with the horizontal force. So for the vertical chopping, you need a sharp chopper, and for horizontal chopping, you need a blunt chopper. So the most important part to chop is to hold the nucleus with the vacuum. Unless we hold the nucleus, we cannot apply our force to chop the nucleus. So it is very important to adjust your foot pedal and adjust your foot. You go to the foot position 3, impel the nucleus with the Pro and come to the foot position 2 and hold the nucleus with the preset vacuum level and apply your chopper to create a crack, and then apply lateral separation force to crack the nucleus. So let us see the video. If you want to eat an apple, you have to hold the apple. Unless you hold the apple, you cannot eat it. So it is practically same for the chopping technique. For foot, you go to the foot position 2, apply the ultrasound energy, tip enter into the core of the nucleus and come into the foot position 2. There is a partial occlusion, vacuum increases, there is a total occlusion, and then you can hold the nucleus with the Pro and then apply the chopper with the second lobe to create a crack or chop the nucleus. So power setting, we can use pulse mode, we can use burst mode, we can use continuous mode, we can use torsional mode. But for the practical purpose, pulse mode is more practical for the up to the grade 3, and for the harder cataract, it is better to use burst mode. But if you have an advanced machine like Infinity, you can use torsional force for all the foot position, sculpting or trenching or during chopping. Setting of vacuum is very important. This is depending on the grade of nucleus. It should be proportionate with the force you are applying with the left hand. So if in a softer cataract, if you increase the vacuum, then the tip suck the material, you lose the vacuum, and then not able to get a occlusion. But whenever the cataract is very hard, then your vacuum should be raised. Otherwise, if your vacuum is less, then you cannot hold the nucleus with the less vacuum if the cataract is hard, because in a harder cataract, you need to apply much more force with the chopper for getting a crack or separate the fragment up to the posterior plate. So if you divide the chopping into two parts, is getting a crack and separation of a fragment. Let's see, this happens every day in our great festival. This you hold, and this is a chopper. Even it is for the softer cataract, but if it is harder, then if you get a crack and you have to apply the separation force much higher. So, as Dr. Mahanta already said, your position of the chopper must be perfect. The side port must be perfect. It should be at least 3 clock hours from the main port, or you can go up to the 90 degree from the main port for vertical chopping. Unless otherwise your hand will be crowded. Say this is almost 90 degree. If your position is very near to the main port, you cannot apply your force with the chopper. If you could, is the animation. This is a. You hold the nucleus, then apply your chopper, get a crack, and separate. Up to the grade 3 cataract, you can apply. You holding the cataract in the same position. position to get a crack up to the posterior plate. This is a cataract of grade 3 hardness. This is a conventional vertical chopping. You can see that this applied the force with the left hand with the chopper, sharp tip chopper, get a crack and separation force. So if you go to the detail of the vertical chopping, you can there is a 3 type of vertical chopping. It's a split technique or oblique chopping or classical Nagara. To be frank, no one nowadays is practicing the classical Nagara chopping technique. This is you are occluding the nucleus here, and if you apply your vertical chopping just nearer to the holding area, then it is called as a split technique. But when you are applying slightly away from the where you hold the nucleus and bring your chopper towards the to get a crack, then it is called as a oblique type of vertical chopping. Let's see. This is a classical split technique. One, and they are holding the nucleus, go beyond the plexus margin, get up to the pectoral. This is a oblique chopping. This is quite different. If your cataract is hard, or if your chopper has a cutting edge, it is better to do a oblique chopping. But if your chopper is a combo type, it's a needle type, then it is better to do a split technique. To start a chopping, it is better to the half trench. Let's see once again. You make a half trench here. When you start your chopping from the stop and chop, half trench here, and then do a oblique vertical chopping. This is a beginner. This is a very good technique on beginner who is doing his stop and chop technique and can start direct chop technique applying this, follow this technique. Central debulking is a very important step to chop a very hard cataract, because it reduces the thickness and create a space to hold the nucleus. This is a central debulking was done, and holding the nucleus almost paracentral area, and it is a vertical split technique. So as I said, debulking reduces the thickness, hardness, and creates space for the chopping. Multi-level chopping, we use this multi-level or multi-planar chopping for the very hard cataract. Here you have to hold the nucleus in the deeper part. Once you get a crack, then you shift your probe deeper layer and again hold and apply your chopper to separate or to break the posterior plate. This is a video of multi-planar chopping. It's a hard cataract. Get a crack, try to separate, but you're not able to break the posterior plate. And now you hold the deeper part of the nucleus, again apply force and to get a cracking up to the posterior plate. Again, holding here. Split technique, I am using split technique and going deeper, and now applying the force. This is called a multi-planar or multi-level chopping for hard cataract. Vertical chopping, I recommend vertical chopping for the very soft cataract up to grade 3 it is better to do chopping in grade 3 or grade 2 or grade 2. This is a very soft cataract, and you can aspirate to you can see that there is no power almost, just tickle the nucleus without any power, only in the vacuum, and you apply your blunt chopper up to the periphery and you are able to make a crack or chop the soft cataract. This is horizontal chopper. Here I am applying, I am just demonstrate for the demonstration. I make the video. This is a central pinch. I emulsify the central part. Then I make the power 0 and holding with the very low vacuum. You can see 0, 0, 0. And now, basically, horizontal chopping is a force which is applied from the equator of the lens up to the center of the nucleus, and it is very, very useful for the softer cataract. Thank you very much.
Thank you, Arup, and I think we went on from SICS, how would we improve phaco emulsification in all our SICS cases. We told you about the Booth's eye wet lab. We told you about how to trench the nucleus properly. We also will tell you about how to separate them properly, and then how to chop them initially, and we showed you the 4 quadrant techniques, and then Dr. Anmato will tell you about the stop and chop technique, and finally we can go for direct chopping in all cases, which was discussed at length by Dr. Arup Bhome. Now we have got about 25 minutes in the course left. So would you like to take up your questions, or I would discuss a little bit of epinuclear management with you? What do you want? Go with the epinuclear management? Okay. So if you have delaminated either by choice or by mistake, you end up getting an epinucleus. And mind you, this is one of the most difficult parts to manage, because there is nothing here to. So first thing we must have is we must see that we don't use energy at this step. So never go to foot position 3. Consciously, that must be embedded in our mind. So let's play this video all over again and see, when we are holding this piece, there is no power, only by if we need to, while holding we should not use power while picking the epinuclear part. Maybe to emulsify also epinucleus would require some amount of power. Now this is another epinucleus which has got a big chunk here. So you can use a blunt instrument like a blunt chopper or a hooklet to actually get the nucleus out, and that is why we've been emphasizing on the utility of a big rhexis. If you have a small rhexis in this case, it will be very difficult for us to pick this epinucleus out of the capsular bag, because just beyond that is the posterior capsule. So we need to be very careful not using any vacuum while picking it up from the periphery. So once we have brought one in, you can use energy or a little hold on that to pick it up and emulsify it. The other simple way of doing it is to do another hydrodissection at this stage, a little debulking of viscoelastic in the anterior chamber. Go ahead and hydrodissect once again. DP nucleus, as you see, popped up into the anterior chamber, and now it's easy stuff. You can inject some viscoelastic behind the EP nucleus, and now get in with the phaco probe and just suck this EP nucleus out of the eye. Now another technique that I would like to share with you, since soft cataracts would become an impediment with you to begin with, is always a hard thing for a beginner. So, I mean, in case you are committed to your patients for phacoemulsification, we always pass through that stage. Do a big rhexis. Initially, we should not bother about the lens margin overlap. And I would recommend that you do as big a rhexis as possible, and as you extend this nucleus out, you must be absolutely sure that it is a soft nucleus. Just bring it into the anterior chamber. The Americans call it supracapsular phaco. Basically, it's anterior chamber phaco. But if you go with the CD, just see it has not even crossed one for half of the nucleus, and I'm sure we will finish this in less than, you use more vacuum to actually take in the nucleus rather than the energy. So, I mean, for anything which is beyond, below 3, 4, I think it is safe in the anterior chamber if you do a supracapsular phaco. But again, to re-emphasize, it has to be a real soft cataract, and it is a good escape in a soft cataract. In slightly softer ones where you find it difficult to chop, you can try this, because here there is a central small nucleus, so you do trench that nucleus with 2 or 3 swipes so that you get trench to crack. And now, as Dr. Manush has demonstrated, go to the depth of the nucleus, preferably in the periphery, crack the nucleus into 2 pieces, and now you need not try to chop this nucleus, because it's very difficult to get a chop in such a soft cataract. So all you need to do is go to one end. If it's a big rhexis, you can actually pull 1/2 of the nucleus out of the eye. Remember, we have already emulsified the hard part with 3.3 energy, and the rest of it would not consume another 1 or 0.5 energy at the most. So this is another technique which is good to follow, where you can actually flip the nucleus out of the back, the 2 pieces, and emulsify it in the anterior chamber, because we try to chop with these soft cataracts. Often with the usual expertise, you cannot chop. There's hardly anything to chop, so you can do a supracapsular phacoemulsification. Again, no energy to hold that, when that nuclear fragment, because there was hardly anything hard there, so no energies, and you can emulsify it. So again, recapitulating the advantages of smaller rhexis with bigger rhexises, because if you have a small rhexis, you get a small trench which will not divide, which is difficult to crack, which is not effective. When you are going to chop, you may chop the rhexis. So all kinds of problems. So the incision on the lens, that is the rhexis, has to be big enough. The fragments can be hidden under the rhexis. It is very difficult to break this fragment out, and actually by holding, we may injure the rhexis. So again, emphasizing these basic points once again. So let me tell you that this instruction course is already being posted in the YouTube, and in case you want to see it again, you can just go to the YouTube and write converting from SICS to FACO and type my name. You get this instruction course. It is the full course, maybe more in it, with the audio commentary in it. So you can watch it, you can download it, share it with other people. And so now we are here. Can we have the mics activated on the floor? And should you have any questions to ask, we will be most happy to answer them. So how many of you are doing FACO on a regular basis here? 1, 2, 3, 4. So half, 1/4 of them. How many propose to do it? I think all of you, otherwise you shouldn't have wasted the afternoon here. That's right. So how are you planning? Does everybody of you who are planning to switch over have a microscope and a FACO machine? Good. For people who haven't, buy a FACO machine, and if your microscope is not good enough, buy a good microscope. Nothing extraordinary. An aqua brilliant microscope is brilliant, I must say. Having got that, do the bullseye exercise, and I'm sure it is nothing changing. I also thought 10 years back that it is some rocket science which that big machine does. It's very simple. Step by step, do the bullseye. When you are sure you've done it well in the bullseye for umpteen number of times, go ahead and do it in every case. Every private case that you are operating. And whenever you are uncomfortable, our good friend SICS is already there. So you can switch over. And having done that, I think it's just about a month's time that you can promise and deliver FACO emulsification to all your patients. Any specific questions, please don't be shy. Ask us, we'll be most happy to answer. Come to the mic.
So if I don't have foldable lens and I have rigid lens, so whether we should go clear corneal incision or scleral incisions as in SICS?
Yes, if you don't have a foldable lens, my first recommendation will be don't do FACO emulsification. Otherwise, I told you do it the way I showed it in the first video. Do an SICS incision. I think enlarging that incision would give you less astigmatism and the wound would be more stable. Of course, there are still 5.5 millimeter keratones available in the market, blunt keratones by which you can enlarge a corneal incision. But my first choice is why do FACO emulsification if patient cannot afford a foldable lens. So make sure at least they can afford a foldable lens. And otherwise don't book cases on a regular basis for FACO emulsification. Yes.
What type of trauma?
Come here.
In the initial phase, what type of trauma you would like to?
Yes, Arup, you take
It's
it.
not sharp shot.
I think a sharp chopper will be Arup's recommendation.
I take a sharp chopper for vertical chopping. You want to use in the vertical chopping. It is better to use combo chopper, the needle type chopper. 0.75 teeth is a 0.75. This is available in any surgical instrument company, and I am using Apashani combo chopper quite a long time, almost 10 years. You can get it from Apashani 0.75 combo chopper.
The plan of chopping is, first to do the trench and divide the nucleus into two. Practice top and chops in all of your cases. Then pick up the grade 3 cataracts, that is the ideal to chop. Do vertical choppings in these cases. Then actually the horizontal choppers or the blunt choppers are most effective only in soft cataracts. Lesser than grade 3. That is where their use comes into action. So, of course, there are certain specific indications which are specific for complicated surgeons like Varun, where you use blunt choppers, but generally vertical chopping is the way to go. Horizontal chopping only in soft cataracts. The other option available is the supracapsular. Don't be worried if the cataract is soft, don't be shy to do a supracapsular thing. I was seeing another gentleman stand up for question. Please, sir.
Sir, actually you told us to beginners practice on the both side.
Yes.
It's good. Is it necessary to go for a phaco training? Or else even after phaco training also you need to go for both side? This one has.
I think it is better to commit yourself with these kind of machines that you are having. If you are doing 100% rexis, 100% hydrodissection, 100% nuclear rotation, buy a phaco machine for yourself. You perhaps don't need. You can come to our institution and watch get 100 phacos being done, or every OT. Go to a center which has TV monitors with every operation theatre and see for a day. It is very difficult for a practitioner to take 1 month off for a phaco training course. We fully appreciate that. I'm sure you won't need it, but in case you need it, there are an option of phaco training courses. Yes, I mean that is the plan.
If you are not trained,
Sorry.
you do not have that sort of training certificate. Is it going?
No. I think you are perfectly justified to do phacoemulsification, accredited to do phacoemulsification to your patients without a certificate. You must be true to him and don't damage his eye. That's all.
Thanks.
Sorry, posterior subcapsular cataract. Yes. I think most of the posterior subcapsular cataracts that you will get would be the soft ones. So in your initial part, just do a big rexis and do a delamination, take out suck out the epinucleus or use energy to take that part out, and then one thing you need to be clear that at no step the anterior chamber should deepen. But at the beginning, please avoid posterior polar cataracts. If they have PC length in the other eye, definitely avoid. Go for SICS, which we are more accustomed to. And as you grow up, you will understand what not to do. As I said, the chamber should be stable and you must be effectively using your forces so that actually the chamber doesn't, and use viscoelastic liberally. So these are the tips for posterior polar cataracts. Sometimes true posterior polars and pseudo posterior polars are difficult to differentiate. But I would again say anything that looks like a posterior polar cataract, do SICS to begin with before you are very accustomed to go. In case you are, the tips are don't let the chamber shallow, use viscoelastic frequently. Delaminate and leave the nucleus central. Yes, sir.
Hello.
Yeah, I think step by step we told you, buy your machine, buy your microscope, do the both side. Phaco to SICS, right. That's a very interesting question. You must go to all the SICS surgeons who are sitting here. We also do SICS because many people cannot afford foldable lenses. It is all about learning to do that incision. And in between of the case, you need to do it when you have a big nuclear fragment and you have a PCR. Now what to do? You need to convert. So in that case, fill the eye with viscoelastic so that it becomes very tight, and then do to the scleral incision, the scleral tunnel, the corneal flap wall, the internal incision, enlarged. That is how we do SICS, right? No, but again, we have a course on SICS basics. That's also on the YouTube. Type my name, SICS basics. You will know everything about the incision.
So, how many cases of scleral tunnel? Yes, this way, sir.
Yeah.
How many cases of SICS tunnels should we attempt before going into clear corneal incisions?
You would know it best.
Huh?
You would know it best. The moment you know, the SICS incision in the first video that I showed is a perfect SICS incision except that it is slightly closer to the limbus. Now you are saying after how many should you go to corneal?
Yeah.
Corneal incisions? I mean, when you are doing your cases almost 100% with this method, you just switch over to corneal tunnels. I'll say corneal tunnels are more easier because you get more access to the nucleus. Because here you are slightly posterior behind, so the access is slightly difficult.
And the iris keeps coming on this.
That has to be, your eye wound has to be tight. You are not creating a proper valve if you are getting iris in the wound in the incision that we show.
So
It has to be a corneal incision in a scleral tunnel.
So
Yes.
how many trenches, like divide and conquer is what I'm doing now. When can I shift over to stop and chop and divide and direct chop?
When you are divided the two nucleus into two, try to do the chop.
Stop and chop.
If you cannot do the chop, then do divide and conquer. The logic is very simple. Go step by step. There was somebody here for a question. You, sir?
Yes.
Yeah, please.
Sir, after previous video, I observed there are some lens fiber attached to posterior canals. I am using bimetal injection, and I tried to remove with cataract board, but still I am not being satisfied.
I take just the hydrodissection canal. I have understood your question. There are some fibers sticking on the posterior capsule which you cannot remove with your eye. That's the question. I use the hydrodissection cannula and just flush sharply on those fibers. Generally they come out. If somebody wants to share something, some other technique to polish the posterior capsule properly?
I follow the same technique. I just give a jet of water with the same cannula, hydrodissection cannula, slightly forcefully, and then it will remove on the first course.
Yeah.
Sir,
Go
the
ahead.
agreement with the patient is that I should complete the FICO. But if I am able to complete the FICO and if I do the surgery up to SICS, should I refund the money to the patient? What is the legal cover?
There is no legal format. It is up to your ethics. If I were the surgeon, yes, I would say that I have converted, and more so if my skills didn't permit it. So initially 5 out of 20 cases maybe you have to do these refunds. Don't be shy about it. I mean, tell the truth to the patient. At least I would have done that. We are not legally bound to do. Legally, that's for the court to decide. There is no law in ophthalmology. We are legally bound, morally bound, ethically bound to our patients. So I think you all enjoyed the course as much as we did, giving it to you. Again reminding you, SICS and converting from this is on the YouTube. Just type the name and type my name. That's my patent from that, and you can download